are here, and I'm going to share good times and a lot of knowledge with you. For the beginning, I'd like to ask our very well-known colleague, Dr. Gianpaolo Gini, president of EVRS, to introduce the first speaker. Gian?
Thank you. Thank you, George. The first speaker really doesn't need an introduction. He is well known in the world of ophthalmology. He is an accomplished surgeon. He is the head of the ophthalmological department in Bursa, Turkey. His background is extremely solid. He worked with Professor Deutschmann at Gulag University, and his surgery is well known through his live surgery events throughout the world. So there's not much I can add to what you already know. And obviously, I am talking about Remzi Abchi. Remzi is going to talk today about the role of retinectomy in chronic hypertonia in complex retinal detachment. And he is a member of many societies, but he honors us with his membership in EVRS. Remzi, it's all yours. Thank you.
Thank you, Gianpaolo. Hi, everybody. In my talk, I would like to present a case with recurrent complex retinal detachment in which I had to undergo a large retinectomy, and would like to discuss the etiology and pathogenesis of the chronic hypotonies. These are my financial disclosure. This is 48 years old man. He complained of vision loss for 6 weeks, and he had vitrectomy gastrointestinal surgery 4 weeks ago. Then in another center, then referred to me with recurrent total retinal detachment, as you see in the video. So the retina is completely detached, and there is 360 retinal tears around the equator. When I start to peel the membrane, I observe that the small retinal tear coalesce and become large retinal tear. So notice that the connection is provided by proliferative membranes, and apply the same thing in other places, same. And so I can see that the connection between anterior posterior retina was only the large vessels area. Then decide to remove all anterior retina flap 360 and remove the connection after diathermy, and attach the posterior pole of the retina and remove all anterior retinal flap 360 completely. Pay attention to remove all retina, all vitreous, to prevent to remove all potential scaffold. The laser scar formation, band-shaped scar formation coincide the 360 retinal tear. Probably the cause of retinal tear was heavy laser apply, which applied in the previous surgery. Then we attach to retina, we apply laser to 4-line lasers, then 1,000 sensor silicone oil. This is 3 months after the first surgery, and 1 month after silicone oil removal. As you see, retina is completely attached, PVR did not develop. Visual acuity improved to 20/100, and intraocular pressure is 16 mm mercury. Another patient with total complete funnel-shaped retinal detachment with severe anterior PVR. In this patient, we had to apply not only 360 retinectomy, but also radial retinotomy to be able to attach to retina. And after laser and 1,000 sensor silicone oil injection, this is after silicone oil injection, and this is after silicone oil removal. As you see again, retina is attached, and vision improved 20/100, and intraocular pressure is about 18 mm mercury. So going back to our question, is there any relationship between retinectomy size and hypotony rate? So on the literature, only Kirchhoff will say yes. However, there are many studies arguing that there is no relationship. Another interesting point that we observe high rates of hypotony after retinectomy in older studies is about 20%. When we look at the recent studies, and the rate of hypotony after retinectomy decreased about 5%. So I think that development of vitreoretinal surgical technology, and especially also particularly visualization, as well as understanding of vitreous space for chronic hypotony, play important role reducing this rate of chronic hypotony. So On the other hand, various studies report that this problem can be treated with aggressive anterior PVR dissection in case of chronic hypertony. And in this series, the recovery rate after resection of recovery to hypertony after resections vary between 27 to 58%. So all of this findings support that rather than retinectomy, ciliary body damage and long-term atrophy due to the anterior PVR and traction of cyclic membranes may cause chronic hypertony. And in their UBM study, Rotter et al. Reported 80% of patients ciliary body abnormality with chronic hypertony, such as ciliary body detachment, traumatic cyclodialysis, ciliary body atrophy, membranes of cyclic membrane of ciliary body, and also, as you see here, also cyclic membrane with tractive cyclodialysis. So, in conclusion, ciliary body shutdown due to the anterior PVR and traction may be the main cause of chronic hypertony after rather than retinectomy. However, therefore, aggressive anterior treatment of anterior PVR may reduce the risk of developing hypertony and treat hypertony if present. However, it's not possible to simply define the exact mechanism of hypertony. There may be more than one contributing factor. This is open for discussion, and therefore complete membranectomy should be performed first, and then, if necessary, retinectomy in complex anterior PVR cases. Thank you.
Thank you, Ramsey. Shem, would you like to have the discussion now or later, Jorge?
No, it's better now.
Okay.
It's incredible. The idea is good. And I think that if you could completely clean the vitreous base from retina and the vitreous, maybe we can save a lot. But I left over Gianpaolo to start the discussion.
Ramsey, I have a question for you.
Yeah.
You usually indicate the UVM in cases like this, because you know perfectly when you have to operate several times an eye, the ciliary body, as you said, suffer, and sometimes it became atrophic or detached. And after the surgery, we have hypotony, and this kind of eyes finally keep the silicone oil for a long time, because you take it out and then you became a hypotony eye. So it's indicated for you to make an UVM before operating this eye?
Yeah, it can be a good idea, but we don't have UBM in our clinical practice, and therefore we cannot check. But especially in chronic case, it's really better to see the position of ciliary body. If there's any membrane, any detachment or atrophy, would be a good idea. If we have it's available. It's not available in our practice. Especially we observe ciliary body problem in chronic case, in traumatized case, and it would be good, but it's not in the daily practice. I think it's a few centers that they have, but we don't have.
So, Ramsey, thank you for this. So, from what you say, and from I think the general consensus on this, timing is rather important, because the longer you wait, the more damage not only occurs to the retina, but also to the ciliary body, because it can detach due to the traction, it can become atrophic due to the cyclitic membranes. What are your ideas on this? How quickly would you say you should intervene in a recurrence of PVR? Because there is an old school concept about waiting for the maturation of the membranes and all this, which I think is surpassed. What can you comment on this, please?
So, as you all know, that the first surgery is in retinal detachment case is extremely important. And if you do a good surgery, if you clean all the vitreous space, if you do everything perfectly, so the rate of PVR is really less. So usually we observe anterior PVR after failed surgery. And the primary case, usually we observe posterior PVR. And therefore, the first primary surgery is extremely important. As you notice that if the patient has chronic case, we usually observe ciliary body detachment, ciliary body problems, and therefore, when we observe case with recurrent PVR, and I think we did not wait a long period of time, we do the second surgery as early as possible.
Thank you.
May I have a comment on Ramzi's talk?
Sure. Go ahead.
Ramzi, congratulations. Great presentation. Actually, there are two comments. First of all, I would love to have the OCTs of the two cases that you have presented, because I saw that there was an epiretinal membrane when you removed the silicone oil, and maybe the vision would be much better or slightly better if you have removed the ERM while you were removing the silicone oil. Second comment that I would like to make is that the papers that you presented from almost 30 years ago, presenting the high rate of hypotony after retinectomy, we have to think about the instruments that we used to use at that time. The 20 gauge instrument that at that time we used to use, it was very traumatic. Mm-hmm. And all the damage that we were creating on the ciliary body was tremendous. Plus the illumination was so minimal that we couldn't see the anterior PVR membranes and we couldn't peel them. So most of them, 1 in 2 cases, ended up with severe remaining anterior PVR membranes on the ciliary body, and that ciliary body were detached, and that's why we had the hypotony. Now, with the new visualization system, with so illuminated light pipes, and also the chandeliers, and the ability to shave the vitreous base and to remove the membranes, that's why all the newer papers present low percentage of hypotony. I think this is the critical point. We have to forget the old papers, the old studies at the 90s and early 2000 papers, and then we need to focus on the new instrumentation, the new papers that we have in our hands.
Okay. I agree what you say, Stratos. Hello, Stratos. Nice to see you.
Hi, Gianpaolo.
I totally agree with what you're saying, but I would emphasize also that, especially for the younger generations, most of the time, the vitreoretinal surgeon, especially when faced with a difficult case, and if possibly less experienced than you or MCR, will deal with the retina. Their main concern is getting that retina flat and attached, forgetting many times that the ciliary body will come back to bite you. So equal attention must be given to the ciliary body. If it need be, you must remove the lens and address the ciliary body with indentation, with chandelier, by manual techniques. Everything that we know we can use, we must use to deal with the ciliary body, so that we do not end up with hypotony, which is the worst case scenario for the patient. The patient will be unhappy if he doesn't see very much, but he will be desperate if he loses the eye to hypotony. So we must focus on that.
Paolo, to move to answer.
Thank you. I completely agree with you about the peeling epiretinal membrane in chronic case. If there is, even if there is no membrane, we should remove ILM on the macular area in recurrent case to prevent epiretinal membrane proliferation. In this, the first case, I did not peel the ILM. There was no epiretinal membrane in the macular area. There was no recurrence, but I was lucky. So usually in my regular practice, I pay attention to remove ILM, and also if there is epiretinal membrane during the surgery in secondary case, in recurrent case. And the other one that all we agree about the new development of especially the visualization. So we can do our own indentation by ourselves. You can see the vitreous space perfectly during surgery, and step by step, and all the vitreous and everything that we can remove is much better than the assistant indentation, and therefore technology helps us to reduce the rate of PVR and also hypotony problems. I agree.
I have one last question, and we need to move ahead. The scientific topic is so interesting that many people are asking. I have one question from Neeraj Pandel from India. How is the experience with endoscope vitrectomy in such case? You think is it really important endoscope, or we can do this with indentation? How you did very well.
Yeah, this is a good question, but I think, George, the optic axis is clear. We don't need endoscope. But if the optic axis is some problem, so absolutely it's necessary. Maybe it's much better than the others. But if the optic axis is clear, we don't need. We can do see vitreous space perfectly with indentation, with wide angle illumination. I think it's not necessary in standard patients.
I agree.
Thank you. Paulo, move ahead.
Our next speaker, he is also very well known. He is the head of the Ophthalmology Health Center in Athens. He's a very, very well-known surgeon. I am pleased to say that he is also part of the EVRS, European Vitreoretinal Society's board. He has been involved with many other societies, heading Medical Retina and many more, which I will not mention for brevity's sake. Stratos Gotsaridis is our next speaker, and please, Stratos, would you present your
Thank you. Thank you very much for your introduction, Gianpaolo. I'm so happy to see you. Let me share the screen with you. Can you see it? Of course you can, yeah.
Yes.
I also would like to salute Ramsey, that I just commented him, and most importantly, Marcelo Zas from distant, beautiful Argentina. Hello, Marcelo.
Hi, Stratos. Nice to see you again, my friend.
Nice to see you too.
Pleasure.
Now, I'm not going to talk about a real PVR case, but I'm going to talk for a potential PVR case, and post-trauma large vertical retinal break in a young patient, 17-year-old male who had a fight, and then 2 weeks before the presentation to our center, he had this injury. The vision was really low, hand movement, the pressure was normal. This is how the eye appeared, quite large from the superior arcade almost down to inferior arcade. You see the elevated edges of the retina. He had visited several centers, and all of them either suggested no surgery or to do laser or to do oil and laser. And when he presented to our center, you can see the subretinal fluid that he started to accumulate in both sides, superior and inferior of the hole. And also you see the large RPE gap that he created in the macular area. You see the SRF, the subretinal fluid, and the gap in the middle. So he came to my practice. I saw him, and I'll say, I'm going to operate you. And the target was to treat it as a large macular hole. I didn't want to create any laser or cryoscar on the surface of the macular and surrounding area. So I started to do the vitrectomy from the 6 o'clock, where the posterior vitreous detachment due to trauma had started to separate, and then went to nasal side of the eye and gradually started to peel very gently to create the continuous PVD through to the temporal side. And the aim was not to lift the detached edges of the break. So once the vitreous was dislocated, I placed the dye and I started to peel the ILM and to cover with these flaps of ILM the large retinal break. I peeled from the nasal part initially, and then I went to the other side, to the temporal side, extensive ILM peel, extensive, in order to make more flexible, to liberate the retina, to be more flexible, to close, to allow the edges of the break to come closer. And then more extensive ILM peel as much as possible. As you can see there, initially the ILM was created with contact lens and then with the reside yellow lens. I placed steroid in order to find the residual ILM flaps or pieces. I didn't find any. And I created a little bit of laser just at the edges of the break in order not to be extended. And I ended up with SF6. So this is the case before the surgery, and this is after the surgery. This is the OCT before with the subretinal fluid in two sides, and now the same places without SRF. And you can see how the gap closed. Luckily, the foveola was on the nasal part of the break, so it was totally unaffected, and the vision improved to 6.5 4 months after the operation. The only thing that has changed, he was emmetropic initially and then converted to minus 1.5 diopters, myopic, because the foveola was moved backwards due to the trauma, and he created a little bit of myopia. Thank you very much. That was my case.
Wow.
Thank you, Stratos. Lovely, lovely case. A very intelligent way of dealing with a very complex case. So in other words, you're using the ILM to bridge the gap, hoping that, as actually happened, that proliferation will happen on the surface of the retina and therefore close that retinal tear. Right.
Yeah, correct. Actually,
yes.
how the to my opinion, how the flap works. The flap actually isolates the intravitreal cavity with the lumen of the break, creates a barrier, and then allows the RPE pump to start to aspirate the residual fluid into the lumen of the large macula hole, or in my case, into the lumen of the two edges of the tear, and try to peel and pull close to the RPE, the two edges. So not only the buoyancy of the bubble that pushes the edges to go close, but also the power of the RPE, of the exposed RPE pump, that creates some traction to the edges of the hole or to the break to come close.
So that was very, very brave. Ramsey, I think you have a question.
Yeah, Stratos, it's great case. I congratulate. So the peeling of ILM all around the retinal tears, extremely good idea to prevent proliferation around the age. Because if we leave the ILM, it work as a scaffold, and the proliferation will start around the age, and retina may contract or detach. So I didn't see exactly. Did you apply laser all around the age, or only some part of the age? So why I'm asking this question, because I would like to see that the ILM flap can work separately without doing any laser about the attachment of this, or laser also help to make attachment in this patient. Did you apply laser all around the retinal tear?
No, just at the edges.
Just at the two edges. Very, very minimal laser at the two edges, superiorly and inferiorly.
But why you apply laser? So why did you leave?
I didn't want to extend the break, first of all, because of the push of the bubble. And secondly, I wanted some kind of adhesion steadily with the creation of a scar in an area which is not important to the vision. That's why I applied laser.
So a
Gita,
really beautifully thought out case. That's what impressed me the most, is that you really took the time to think about each step and how you were going to approach it. I'm curious, do you think that this young boy is going to have a much higher risk of CNV going forward? And what, if anything, could you have done to think about that, to see if, what more could you have thought about to prevent that?
Congratulations on your question. This is the most important part of this surgery now. The CNV creation in the future because of the RPE break. You are absolutely right. I don't think there is something that we prevent that. We just need to follow him up. And once we exactly. And once we see it, we start to inject anti-VEGF. This is the only risk in the future of this eye. You are absolutely right. Congratulations for your question.
Stratos, why SF6 and not a longer acting gas?
We don't need longer acting gas. You don't need longer than that. I mean, maybe only air could be enough. Just SF6, 10 days of a nice big bubble, it's enough. And posturing for 5-6 days, and that's it. It does the work.
So did you posture him? Yes, of course.
Oh, yeah. Strictly posturing for 5 to 7 days, strictly. 24 hours per day.
Okay.
And also Stratos, great case, amazing case. Congratulations again, my friends. I think that you the first topic that you said, that you need a complete posterior vitreous detachment in young people with retinal tear with detachment. I think that what was the key of the success, and I really was amazed about that use the ILM to create a scaffold to heal or to have hemopexy in the large retinal tear with no detachment. I think you have to publish this case because I think it's a new way. Because if the ILM can be as a laser or to carry a scaffold in that posterior break, and I agree with Jeev about the risk of CNV in young people.
Stratos, good to see you. A great idea. I really learned how to do a new way to block the rupture of the retina. And I have one question from the audience, Dr. Pandey. He said, was it more of ellipsoid zone thickening and rarefaction rather than subretinal fluid? You agree that?
It's not more of easy thickening. No, it wasn't SRF. It wasn't thickening of the zone. It was SRF. It's obvious in the OCT that it's SRF. And if I go back to the initial color picture, you see the grayness that SRF creates. It wasn't thickness, it was SRF. And the OCT, fortunately, has presented that.
Oh, good. Thank you so much.
Thank you, Jorge.
So I will sum up simply by thanking all of you. And if you did like the cases that were presented, may I remind everybody that EVRS holds its annual meeting. This year it will be in Budapest from the 14th to the 17th of November. The abstract submission forms will be out soon. So just grab a pen, write down the date, 14th to 17th of November, and you'll see more of these wonderful surgeons and their cases. Thank you.
Thank you so much. And now we have our lady, Dr. Geta from the BRS. Please,
thank you.
All yours.
Thank you. So on behalf of the Vit Buckle Society, I'm very pleased to introduce two of our fellow members. Our first one is Dr. Asad Durrani. He's a second-year fellow at the Wills Eye Institute in Philadelphia. He's going to be discussing a case of recurrent retinal detachment due to subretinal PVR.
Can everyone see my screen?
Yes.
Okay, great. So this is a 24-year-old female presenting with blurred vision in the left eye. She has a macular off-retinal detachment with a large subretinal PVR band. She's count fingers vision. Macula is off here on the OCT. Because she was young and she has a history of autism and developmental delay, as well as retinopathy of prematurity, she first underwent a scleral buckling procedure with cryopexy and a 42 band. She was doing pretty well on post-operative month 2. Retina was flat and attached. She still had this large subretinal band. but it was not causing any issues until she came back on postoperative month, between 3 and 4. And again, her macula had detached with new breaks at the edges of the subretinal band. So we're going to go to the video next. So we started, with a core vitrectomy. You can see this large subretinal band. First step, of course, was to induce a posterior vitreous detachment. Which actually came up pretty easily. We did some peripheral shave vitrectomy. And then we started just, decompressing the detachment through this was actually the original break that was treated with cryopexy, but there are additional breaks associated with the subretinal band that you'll see later. So then we started, depressing around. We found there was a couple of breaks temporally associated with this band. And given its size and the contracture, we decided that we needed to remove the subretinal band. So we created a retinotomy with the diathermy, and then we used maxillary forceps to remove the band. It was quite a large band. It was almost like 6 clock hours in the end. So you'll see it's a very big band. Then we put some PFO in to protect the macula. Also, we wanted to see if the retina would flatten. There was still a smaller band here temporally that we decided we needed to remove as well. And also there was some intrinsic PVR in this area. There was so it was still not flattening after we removed that additional band. So we had to remove some retina there. Yeah, but after this, the retina was able to be flattened. And we left this patient under oil. So on follow-up, patient was macula was flat. She was 2,400 at post-operative month 2. We're bringing her in for one more visit to see if she remains attached, and then we'll consider silicone oil removal.
So very, very nice case, Assad. Very nicely done. I had mentioned to him that there was a technique Dr. Ted Lang actually presented at the Vit Buckle Society. When you're moving very long subretinal bands, you can use like a spaghetti twisting technique, and does very nice. Then you don't stretch out that hole. There's much less movement of the eye, but you did a beautiful job of removing that band. I was curious about this woman's ability of understanding, whether I would have done what I might have considered gas when I placed the buckle, because she clearly must have had a lot of subretinal fluid, chronic subretinal fluid, but I don't know what her ability to position was.
She was she's able to do the eye chart and read the eye chart, but not very able to follow directions really. So it's kind of difficult for her to position. That's kind of why they didn't do any gas during the first surgery.
Gotcha.
and why we chose oil, obviously, in the second surgery, because she has trouble positioning, definitely.
And understanding.
Yeah.
So,
I have a question.
say something.
Yes, for sure.
This great case. Another approach to avoid retinectomy in such patients, we can use transcameral approach, transcameral removal of subretinal band, like Khalid Sabti from Kuwait introduced this technique several years ago. So this is also really a very good technique in such patients. So you had to apply 2 large retinectomies in this patient, but that technique you can remove all the membrane without any retinectomy. So also usually the surgeon hesitate about the hemorrhage bleeding during transcameral approach, but apply this technique maybe more than 10-15 cases, and actually there is no hemorrhage problem, there's no bleeding problem. It's really quite a safe technique.
Very interesting.
Congratulations, great job, great surgery. If you face difficulties in peeling this subretinal PVR, you can just cut it and leave them there. Just relax the traction and leave them there. The retina goes flat. You don't have to remove them. Once you see that there is a resistance and you are in a risk to enlarge your retinotomy, you just cut it and leave it there. You don't have to remove it.
Marcelo.
Great case. Just a small advice: when you are in front of these kind of cases, just to use chandelier lights to have bimanual opportunity inside the eye, to build a membrane, to access the subretinal access, to make the spaghetti, such as to take the membrane, just to try to use every time 100% chandelier light to have bimanual technique. And also, when you mark your marcation by diathermy, you just need one spot of diathermy. Don't make too much diathermy, because diathermy can blood, can be reproliferation. You can open retrogenic breaks. Just one shot of diathermy. Just these two points. Great case.
Yeah, I think that would have helped the chandelier, because we had to use the light pipe as counter traction, but also we were using it to light up what we were doing. So yeah, it definitely would have helped, I think, chandelier.
And Gianpaolo.
So everybody is giving you good suggestions, which I completely share, but I want to congratulate you on just one point. When you were actually removing that membrane, you were pulling it in the correctly, not so as not to enlarge the hole. So it's very important that one pulls away from the edge of the retinectomy that you've made. Otherwise, that sharp membrane will cut into the retina and create a larger tear. So you did the right thing, and I think nobody mentioned it, but that was the right way of proceeding. Whether you use a spaghetti technique, which was introduced by Cesare Forlini many years ago, or whether you do it your way, you did the right thing. Thank you.
Thank you.
Very good. I think that the key points is use good light, chandelier, by manual hands, take care to not enlarge your retinotomy, and not necessary to remove all the subretinal bands, because you can cut, and you don't need to do retinotomy in every case. But anyway, very nice case. Thank you so much. Geta, let's move on.
So our second speaker is Blake Fortes. He's a first-year fellow at UCLA, and he's going to be discussing case of recurrent retinal detachment in a pseudophakic with anterior and subretinal PVR.
Thank you, Dr. Lawani, and thank you, everyone. Awesome presentations and cases so far. And I will go ahead and share my screen. So here I have a pre-op image of the patient. The patient is a 61-year-old male who came in with a recurrent rhegmatogenous retinal detachment with anterior loop PVR and subretinal bands. He had had 3 prior parsplanum vitrectomies, including an inferior retinectomy elsewhere, as well as a sclerobuccal, and came in with count fingers vision and hypotenuse with an intraocular pressure of 5. And so let me go ahead and share my video. And so I did this case with Dr. Kirk Ho. And so initially we removed the silicone oil and we did a posterior synechial lysis. There was a very small pupil. We did a posterior capsulotomy, but the view posteriorly was still poor. And so then we made the decision to explant the intraocular lens. We prolapsed it into the anterior chamber with the cutter, and then used lens cutting scissors and lens grasping forceps to bisect the intraocular lens. This was a plate haptic IOL that the patient had. And then we removed this through a superior extended clear corneal incision. And the other reason for the IOL explantation in this case was also to allow adequate visualization during the anterior base dissection. We then removed the capsule in its entirety with maximum forceps and McPherson's. And this is our view after the IOL explantation. You can see there's an inferior retinectomy that looked clean. And then now we're doing deep scleral depression here. And you can see there is some extensive anterior loop PVR. And this extended essentially all the way around superiorly, essentially 180 degrees. And so we take this around all the way superiorly. We then made the decision to do a superior retinectomy. So we did some continuous diathermy along the posterior margins of the retinectomy edge, and then using the cutter here to dissect the anterior retina off. And so we do this all the way around, and then not shown here, but we also take that up all the way anteriorly, remove the anterior flap in its entirety. And that's to prevent not only neovascularization, but also to prevent that tissue from acting as a scaffold for PVR in the future. And then soon we'll be addressing the subretinal bands as well. And so here we're reflecting the retina over posteriorly using the light pipe and cutter. We could have also used chandelier, but in this case we ended up just reflecting it over posteriorly. And then we're using the maxgrip forceps here. We're using the light pipe for additional counter traction to remove that band. And then now addressing another band. This one we actually do the spaghetti maneuver that was mentioned earlier. And then now using the cutter for another subretinal band here nasally. And then one final subretinal band here temporally with the cutter. And so now we're doing anterior base dissection here with the cotton tipped applicator. We take this around all the way 360, removing these membranes here with the cutter. We lay down some perfluorocarbon liquid to flatten the retina. And then we do endolaser 360. We make an inferior peripheral iridectomy. And then we do fluid air exchange, remove the perfluorocarbon liquid, rinse and remove subsequently again. And then we place 1,000 centisode silicone oil. And then we also did an intravitreal methotrexate injection, and that's closure. And then let me share the post-op photo as well. And so this is at post-op month 4. The retina remains attached. The patient did undergo a series of 13 intravitreal methotrexate injections. Vision remains count fingers, however, he does pinhole to 2250. He does remain hypotenuse with an intraocular pressure of 4. And so at this point, we're planning for fitting the lens with an aphakic contact lens. And currently no plans for removal of the silicone oil, given that the patient's hypotenuse, but we'll continue to watch closely. Thank you, everyone.
So, very, very nice presentation of both anterior PVR as well as subretinal. A couple of comments. So one, you did a beautiful job of removing that lens, because sometimes the challenge is removing that lens and not inducing corneal edema, which now affects your visualization, which was the goal in the first place. So very nicely done. So I suspect, and this comes back to our first presentation from Ramsey, that he probably has ciliary body damage to begin with. And what, if anything, could have been done during surgery? But I guess my question for Ramsey, honestly, is when you're removing some of these anterior membranes, is there a technique, do you have advice for techniques to not induce damage to the ciliary body? Because sometimes removing those membranes creates traction and causes the ciliary body to separate and or become damaged.
So let me answer the question. So this is really a great case. You did a very great job. All the steps is really, I agree with you, only except that apply direct silicone oil PFO exchange instead of hair overlap, because this is another technique, but it's also easy way to apply the silicone oil PFO exchange directly without fluid PFO exchange. So this is really good. It's really difficult to clean ciliary body membranes. So first, we need very large angle view and a good illumination. That's very extremely important. And also, sometimes we may need the assistant indentation to be able to work bimanually. If you track the membranes, if you work bimanually without any indentation, if you do own indentation, if you work unimanual peeling the membrane, you can track the ciliary body and you can create ciliary body detachments. And therefore, I usually ask the assistant indentation from the assistant and then work bimanually as much as possible to not to track the ciliary body, to peel bimanually with the scissors and cutting the membranes. But it changes from patient to patient. You can decide during the surgery some of the steps, but that's the critical point that we should pay attention, not to make a strong traction to the ciliary body during membrane removal.
Gita, in my experience, it's generally best, as I'm sure you know, to section, to cut the membranes rather than to peel them. So if you interrupt them, similarly to what you do for subretinal strands, if you do interrupt them, then you release the traction without pulling on the ciliary body and determining a ciliary body detachment. So simply cutting into the cyclitic membrane is generally enough.
I agree. Often you can see the traction release right in front of you as you cut it away. I suspect that he already had damage to his ciliary body before the case was, and so you did a beautiful job.
Thank you, everyone. He did actually. I didn't show the ciliary processes more inferiorly. They did appear to be atrophic during the case.
The last comment.
Yep.
I think it's very important. Yeah, I think the take-home message for all the people who are watching us is to take out the lens in cases like this, because when we operate a pseudophakic eye, sometimes we doubt about take it out. I think that's very important to take it out to peel this ciliary body. If you don't take it out, it's impossible to do it. So if you do a very beautiful work there in the retina with a big retinotomy and very, very nice work, it doesn't work because we don't take it out the lens. So we don't have to do and take.
So this is really about the removal of lens and anterior capsule diagram. It's really extremely important because we usually observe hypotony problem much more frequently in a pseudophakic patient if the lenses remain in place. Also, UBM could be a good idea to see the morphology of ciliary body in this patient, why hypotony still continue after this membrane dissection. I think there could be some ciliary body atrophy also in this patient.
Sure.
But yeah, great case. We learn a lot, but I think the key points we're raising up is take out the lens to have a good view. Take care as much as possible, not trash on the ciliary body. You have to clean.
May I have a last comment for these patients? The other point, in this patient, if there's ciliary body traction or atrophy, there is no aqueous production. And when we apply silicone oil in this patient, usually we see that the anterior chamber is completely collapsed because there is no aqueous production. If there's aqueous production, you don't need to afraid because the UV miracles come into the anterior chamber, and you can see the anterior chamber is well designed. And therefore, in such patient, I prefer to inject viscoelastic material into the anterior chamber before silicone oil injection to keep at least a space during the recovery period and early recovery period to keep anterior chamber collapsing. That's another idea that I can suggest is chronic hypotony patients.
Very good. Thank you so much.
Thank you, everyone.
Thank you so much.
Well done, Mike.
And we need to move ahead in sake of the time. And now our very good friend, Andres Bastien, that's gonna present a wonderful speaker from Sarif, Argentina.
Okay, thank you, George. Thank you. Thank you for the invitation to share this meeting. I want to present Eduardo Zavallo from Río Cuarto, Córdoba. Él es el director of Clínica de Ojos Privada de Visión Río Cuarto, and is an active Sarif member. And thank you, Eduardo, for being here.
Hi, everyone. I would like to thank the event organizers to invite me. It's an honor to present in front of you today. This is the case about a 25 years old man who realized he couldn't see from his left eye after he's suffering a trauma on the right eye. You can see therefore you can see in the video a very old retinal detachment, but I don't know when it happens. You can see a very dense vitreo and pigmented vitreous. I performed the best choriovitrectomy that I could initially. You see a tear in the nasal quadrant and inferiorly. By using active station, I separate the posterior hyaloid, leaving a more mobile retina. As you can watch in the video, the hyaloid has a firm adhesion to the retina. It's strongly attached. You can see the cone inferiorly, a cluster or dots of pigment in the posterior face of the hyaloid, showing us the chronicity of the detachment. I separate the hyaloid, bringing it as forward as possible to clean all the posterior pole. I inject this triamcinolone to expose the residual vitreous, and I take out all the vitreous that I can. Then of this, I injected brilliant blue to peel the ILM. You can show in the video several spots in the posterior retina. In these cases, I decide to remove the ILM. It's difficult to remove with the detached retina. Then I finish to peel the posterior pole of the ILM under perfluorocarbon. Perfluorocarbon is a very useful tool in these cases to help to remove the ILM and make it easier. Next, I clean it and shave it, the vitreous base, but under indentation, like I always do. I try to peel the vitreous base as tidy as I can by indentation, always. I produce a iatrogenic cone in the periphery. But in this time, I touch the lens and I decide to remove it through a corneal incision. I make a capsulorhexis and then put a spatula behind the lens to support the lens fragments dropped into the vitreous cavity. Then, with the vitrectomy, I aspirate all the rest of the lens. I finish this part of the surgery, injecting an intraocular lens in the sulcus. Then I take out some subretinal membranes through the retinotomies. Then I perform fluid air exchange, laser around all the retinal holes and the retinotomies, and then to perform cryocoagulation in a peripheral iatrogenic little hole. I finish the case injecting silicone oil. I decided to present this case as it showcases different challenges that may happen in the complex vitrectomy. Thank you for the attention.
Thank you, Eduardo. I think it was a very nice case. And I want to ask you one question. Normally in your surgeries, do you make biometry before? Because in that case, you planned not to take it out as first the intraocular lens, and then it was a spontaneous touch and damage, so you decided to take it out and then you put it an IOL. So what is the approach to these cases?
It's mandatory for me when I make a vitrectomy in my patients. Always they go to the surgery room with echometry and with intraocular lens calculation. If I can't do in this eye because the eye has a retinal detachment or anything, I use the biometry of the other eye. But always I have I always think that I have the possibility to check out the lens.
I think it's important to differentiate the lens touch that sometimes when we do the shaving, vitro shaving with indentation, we can take the lens with the vitrector, but it's very, very different when we make a damage, we rupture the posterior capsule, then the cataracts became quickly in days. So it's very important to us to differentiate this situation, the touch than the damage.
The touch and the bite.
Yes.
If you have the bite, the cataract is immediately.
Yes, yes.
And then you can decide what technique use. I use this technique in this case, but sometimes I use to left the anterior capsula on site and remove all the lens except the anterior capsula, and I put the intraocular lens over the anterior capsula.
Do you think that for best stability it's better to put 3 pieces IOL or just one piece like this guy?
Yes, always the best for these cases, for retinal complex surgery cases, is a 3 pieces IOL, but sometimes you don't have them and use 1 piece. But it's better 3 piece because it's more give you more stability.
Okay. Any questions, George?
Great case. Thank you, Eduardo, so much. But we need to move ahead because
we're moving to Marcelo Sass, a friend. He's going to talk about recurrent retinal detachment and PVR in a pseudophakic and myopic patient. Marcelo is Associate Professor of Ophthalmology and Head of Retina Section in the Ophthalmology Department de la Universidad de Buenos Aires. He's the actual president of the Argentine Society of Ophthalmology, and he's an academic secretary of the Executive Committee of the Pan American Society of Retinas and Vitreous. Thank you, Marcelo.
Thank you, Andres. I'm going to share my screen. Great, and thank you again, George, Andres, Gianpaolo, and Gita for all the organization, this great vitreoretinal surgeon expert and PBR. I'm going to present my case, and this pseudophakic myopic patient in a recurrent retinal detachment. This is my financial disclosure. And the case presentation is a patient that we received in February 2013, female, myopic -6, phakic healthy patient, has a retinal membrane in the right eye. So we operate the patient with good result. In 2014, we react capsulotomy. He was stable for 6 years with 20/20 vision in both eyes with no medication. But then in October 20, he had an inferior retinal detachment with macula on, and another colleague make a 25J first-part vitrectomy, laser, and SF6. And then for 2 weeks afterwards, he sent us the patient with a recurrent retinal detachment with macula off. The visual was very bad, 2400. So I decided to make a 360 degrees buckle, 25 gauge first-part vitrectomy, photocoagulation, and the retina was stable for only 45 days. Then in November that year, 2020, he has a total detachment, a PVR, macula off, with silicone oil tamponade. This was the image that in 2020, and you can see how was the PVR, the subretinal strands, the retinal folds, when the R's are showing the silicone oil in the PVR with 2100 of visual acuity. So I decided to speak with the patient and take the patient to the operation room. We use digital image in this kind of, we use a 25 gauge with 7,500 cuts per minute. The infusion was put in 30. And we spoke before from Ramsey, we need to have relaxing retinectomy. The relaxing retinectomy have to make complete with the beveled vitrectomy probe, taking out all the anterior retina necrotic flap. I don't was afraid about the bleeding because we had a necrotic flap, so and the diathermy was made before, but we need to have a good visualization. The peripheral carbon can give us the third hand of the surgeon stabilize on the posterior pole. We have to avoid, and we have to be very careful not to migrate that kind of bubbles under the retina. And I love to use, as I spoke before, the chandelier lights, that you have my 3 hands inside my eye, my 2 hands, but I have a visualization that does ingenuity with peripheral carbon, put it there to stabilize the posterior pole. The dual bore cannula. The retinectomy have to be done under and over the healthy retina, just to have a relaxed retina, and then the laser have to be made in 1 or 2 unnecessary lines of laser. Don't love the laser just to make more laser, because more laser can give us more PVR. And as I spoke before, my third hand can give my indentation just to watch and to photocoagulate and the healthy retina, as in the same situation, we are operating giant chair. As I said before, I made a slow motion peripheral carbon air exchange just to dry under the retina, and then air silicone oil tamponade 1400. Here you can see the post-op, the patient, and you can see the patient 2 months afterwards. You can see now the OCT, and we can see the tuning or the slimming with the visual acuity of the patient 60 days after surgery. And I'm going to show you the patient now in 2023, last September, when you can see the good visual acuity. The external retina was respect, but we can see over that timing or slimming of all of the retina, and you can see all the damage of all the silicone oil, the PVR, and the reoperation in a myopic patient that have PVR. And you can see of the OCT can show us all the damage in the optic nerve. I think thank you for your attention. I'm going to open to stop my presentation, open for discussion or comment. Thank you so much again.
Excellent case, Marcelo. Congratulations. I want to ask you, why do you prefer to do the exchange perfluoro air silicone, and no, in case like this, straight perfluoro silicone oil?
That question is a very good question, Andres, because I like to watch. I think when you're doing directly perfluoro carbon silicone oil, you can lose in some time visualization, and I feel more safe for my practice just to dry with air all the retina, to watch the periphery, to watch if I don't have any perfluoro carbon liquid under the retina in that kind of big retinectomies, and then put silicone oil. Silicone oil is not going to repair my PVR. The silicone oil is a tamponade, and so I want you just to make it in scales. But that is it's a very controversial situation. And the intro, if you do a directly exchange or you do a three phases of the exchange.
Perfect.
So,
See.
yeah, this is Marcelo. This is a great case. So this is my technique. I apply almost the same in such patients. So the other problem with if you apply fluid air and PFA exchange, then silicone oil, you can see the retinal slippage in this large retinectomy. This is another problem. Therefore, actually, direct silicone oil and PFA exchange this is my practice. In my practice, it's much better. I prefer in almost all cases, I never do air PFA exchange. My question is, in such patient, if there is no anterior lip traction, if there is no cyclitic membranes, if the anterior flap of the retinectomy over the scleral buckle, anterior scleral buckle is attached, even sometimes we observe their lasers which applied previous surgery. Do we need to remove anterior flap of the retina in such patient in all patients, or we can sometimes leave this flap of retina in place? Because also we don't know about the chronic hypotony, and to prevent large retinectomy, to prevent hypotony. What do you think about that?
Yeah, that's a good question, Ramsey. We are in our routine practice, we take all that necrotic anterior flap, even with that we have a buckle and 360 buckle, because that retina will not function anymore. We know about the visual field loss about the retinectomy, but it's my practice. I don't want to leave more any tissue that we necrotic and can have us reproliferation. We don't know that about that, but in our practice, I like to do that. It's a necrotic tissue, and I think we will more safe if we take all that necrotic tissue. Obviously, in this kind of cases, I absolutely agree that we have to put a buckle. Now, in those years, nowadays, young fellows or young surgeons, we are 25 or 27 gauge, we are forgetting about the buckle in inferior PVR, and we have to have it in our OR to put a buckle. The buckle is going to help us to let the traction, to control the inferior retina, and to control the folds, and obviously to control the redetachment, and give it laser over the buckle that I show you in the video.
So I mentioned about the patient with buckle previously, but in my practice, if the buckle is in place, if the anterior flap is attached, even laser has been done, I prefer to leave the anterior flap, because if the laser has been done, it's attached, it usually creates any problems and helps also to prevent hypertony. This is but not in all cases, agree with you, but in some cases we can remove, because if the lasers apply and the anterior flap is attached, it's even very difficult and it's traumatized to remove anterior flap in such patients.
Yeah.
Thank you.
Good point, Professor. Thank you.
Paulo?
I just want to make a point regarding the direct exchange silicone oil perfluorocarbon, simply because this question has been made to me by some fellows, and I think it may be interesting for everybody listening. So when you're doing that direct exchange, which is what I prefer, incidentally, I don't go through air because I don't like the idea of possible retina slippage. One must remember that you have three media inside the eye. You have the silicone oil, which is coming from the top. You have the perfluorocarbon, which is sitting on the retina. But in between the two is obviously still some water, some BSS. Therefore, it's important to reach to the periphery as the silicone oil is going in, so that you remove that interface of water. Otherwise, your retina will roll up, it will slip, and you will be very unhappy. So remember always that you have something you don't see, which is that third element being the water trapped between the silicone oil bubble, which is going in, and the perfluorocarbon bubble, which is present on the retina. That must be removed. Otherwise, you will have problems.
Good point, Jean-Paul.
George?
Marcelo, great case. I just want to say some points. In some cases, that the patients has predisposed to PVR, and I'm just doing inferior retinectomy. I don't do laser. I just go directly for the exchange and leave with oil and do laser 30 days after the surgery. And nowadays I'm using methotrexate. I don't have really trial data that's prove that methotrexate really helps, but I'm using, I have the series of 12 cases and looks that helps, but just my practices.
Yeah, I'm agree, George. We know now that PVR is like a black hole because we don't have any clinical trial about to treat in a pharmacology area that we are now, a pharmacology area to treat PVR. PVR is a very complex and very multifactorial disease over the retinal detachment disease. We remember from beginning of the 20s, the British cocktail using methotrexate was failure, and we don't use it in the practice. I think that the treatment of the PVR is to avoid PVR, treating correctly the retinal detachment, watching the patient correctly, or even and to watch in the pre-op examination what patient can go to the PVR, large retinal tears, trauma disease, reoperations, retinal detachment with choroidal detachment, vitreous hemorrhage, but we don't have pharmacology. I hope so to have in the future a clinical trial to compare drugs against a control group to treat in a pharmacology area the PVR. But we don't have it now. You have to publish that, George, or you have to keep on going with that. Really great.
Stratos.
Finish.
I have no words to say that I totally agree with what you have done. Congratulations, great job. And I really like the idea of doing the retinectomy to the edge of the healthy retina. We as surgeons, we need to be aggressive and we need to go in front of the problem, not behind the problem. And taking the last comment about the PVR and the pharmacology, you are absolutely right. We don't have evidence on pharmacology, but we do have evidence of being aggressive and try to take decisions fast, to operate soon, to do bigger operations that normally we think that this is the normal. Try to be in front of the PVR, try to be in front of the problem rather than following the problem. Congratulations, Marcelo. Great job.
Thank you, my friend. Thank you so much.
I think we are close to the end. The session today, I really learned a lot, many ideas, many discussion about physiopathology and how to protect the ciliary body, how to remove the PVR. And so nice to be with you guys and with this friendly atmosphere that's improved so much our friendship and our learning points. And then first I'd like to open for Gita to talk about VBS meeting that's going to be Miami this year. Gita,
Sure.
you are here.
Thank you for the invite. Thank you all for allowing me to join. It was an honor to be here and to hear all these conversations and beautiful presentations by everybody. So a couple of things. We have our VBS surgical rounds where we do very much like this, where we have fellows present cases, and that is next Tuesday, February 20th. If you go on our website, you can register and be a part of that also by Zoom. But the bigger thing is we have our annual meeting coming up in April this year, April 4th to 6th. It will be at the Fountain Blue in Miami, and we have lots and lots of exciting presentations, participations, all kinds of things coming up. So I highly encourage any of you to join if you have younger, especially if you're in younger years of your retinal practice and or fellows. It's a wonderful meeting to be a part of. Thank you very much.
Thank you so much to join us, and I hope VBS still together because I appreciate a lot.
Thank you.
And now, my friend Andres Bastien, that's doing a great job in the SARIV. He's a former president, but SARIV is a great, great society.
Thank you for your words, George. And we're inviting all of you to the end of September and this year in the Villa Langostura. It's a very nice place in the south of the country. We're going to have the annual meeting there with the very important guests and with the friendly and the open heart like ever time. So thank you for this invitation to participate in the Retina World Congress, and we'll see you in May there in Fort Lauderdale. Thank you, George.
And the last one, not the least, Gianpaolo.
Yes.
I know that last year EVRS meeting in Cappadocia was terrific.
Extremely successful. Extremely successful. We were very happy. We had an unexpected outturn. Unexpected because obviously we were coming out of a very difficult period, which is COVID. So it was good to see old friends again, a lot of new faces. The place was beautiful, but a bit difficult to reach. Next year we'll have somewhere that is going to be just as beautiful, but a bit easier maybe to reach, which, as I said before, is going to be Budapest from the 14th to the 17th of November. And of course, we'll have the usual EVR's atmosphere. We'll have all the presentations, the societies. It will be a great experience, a great learning experience, but also a great experience from a friend's point of view, because we'll be meeting up with old friends and making new ones. I hope you can come.
Yeah, for sure. I'd like to join you. And then it's the end. It was a great session. I really appreciate a lot to be together with so good friends and new friends. And we are preparing the next session, going to be February 25 with the Canadian Retina Society in Mexico Association of Retina. I think we're going to have very good times again with a lot of good case, and together have to thank you and thank our sponsor, Regeneron, Genitech, Appels, and Coherent. Thanks so much. Enjoy the rest of your Sunday. See you soon. Bye.
Thank you so much. Bye. Bye, everyone.
Thank you so much, friends.
Bye, everybody. Bye-bye.